This is the second of two videos on operative vaginal delivery. Today we will cover key prerequisites, outlet forceps, vacuum extraction, forceps for the aftercoming head, as well as complications. The key prerequisites for operative vaginal delivery, for review: cervix must be fully dilated, the membranes have to be ruptured, the fetal head has to be engaged, and importantly, the position of the fetal head has been determined. There's been a fetal weight estimate, and that there's adequate anesthesia. In examining the patient, again, you should know where the fontanelles are. As shown here, you can see the posterior and anterior fontanelle with an LOT presentation with normal synclitism. Occasionally, you'll have some minor degree of asynclitism, as shown here, anterior asynclitism. When this occurs in either an LOA or ROA presentation, certainly that often can be corrected fairly readily with the use of the outlet forceps. Important to know what the various planes are of the pelvis. The high plane is basically the inlet. You have the midplane at the level of the spines. And again, when the presenting part is at this level, usually we say it's engaged. And then you have low, mid, and low. It's in the low area that, again, you have outlet forceps, as well as you would have the low forceps. So outlet forceps basically mean that the scalp is visible at the introitus without separating the labia. The fetal skull has reached the pelvic floor. The fetal head is at or on the perineum. And the fetal head is in OA, OP, ROA, or LOA position. And that rotation does not exceed 45 degrees. With low forceps, the leading point of the fetal skull is at a station of +2 centimeters or more, but not yet on the pelvic floor. Without rotation, you would have any degree of rotation, a small amount from an ROA or LOA to OA, for example. And with rotation, the rotation is greater than 45 degrees. Here is, again, a fetal head showing these various positions or stations of the head. Again, most of the time we will be dealing with what would be low mid or low forceps, as well as low, which would be outlet, where you can see that the head most likely is spreading the labia. And also note that the head tends to rotate much more towards an OA position as it further descends into the pelvis. And this has importance in terms of what direction or vector you use to exert traction. And in general, we'll be looking at 3 and 4, and you can see that there is some difference in the direction depending on what the position or the station, rather, of the fetal head. Here we're getting ready to apply an outlet forceps. You have a diagram of the position as shown on the upper left, and here is what we call ghosting, where you sort of hold the forceps similar to how you will apply them. Note that the right blade is on top, and that is applied secondly so that you have a better ease at actually locking the blades. So with the initial application, that's the left forceps. The handle is towards the right groin of the patient. The operator's hand is showing or holding the blade against the occiput of the fetus, and it's inserted in front of the ear, again maintaining pressure the entire time. Now, occasionally you do it in the opposite approach, only if, for example, there is an ROA, such that if you applied the forceps, as shown here, the left forceps first, you may increase the degree of rotation. But by applying it posteriorly first, it prevents further rotation of the head. Once this left blade is on, then you apply the right forceps in the same way, the handle towards the patient's left groin, holding the blade against the occiput and applying it, sliding it in in front of the ear. Once you have it in place, then you basically have to make sure that, in fact, the application is appropriate. So to check placement, relative to the posterior fontanelle, it should be midway between the sides of the blade and about 1 finger breadth above the plane of the shanks. Sagittal suture has to be perpendicular to the shank, and the fenestrations or blades should be tightly against the fetal occiput with minimal space between the shank and the head. Traction is then carried out. The Saxe-Torp-Pajot maneuver, as shown here, involves the left hand, as shown here, exerting traction in a downward direction, while the right hand is exerting traction outward, such that the overall traction may be, let's say, 30 or 40 degrees in a downward direction. To facilitate this, one can use a bill axis traction as shown here, which allows one to do this without having the same degree of guesswork you would have by doing it manually. Once you've completed almost the delivery of the head, the blades are removed in the opposite way that they were put on. That is, you remove the right blade followed by the left blade and maintaining the head by use of a modified Ritkin maneuver. Occasionally, you will need to rotate from, let's say, an LOA to OA or ROA to OA. Note that the usual traction forceps, and again, these are Elliott's, but the same would be true of Simpson's. With the usual traction forceps, you can see the blade is above the perpendicular of the shank, so that if you just twisted the handles, you would then carve a fairly large arc of the head, which would make it difficult to rotate the head and also potentially increase the risk of vaginal laceration. Therefore, to rotate with the usual traction type outlet forceps, again, you rotate the handles in a much wider arc, using, in a sense, the toe as the fulcrum of the forceps. Obviously, this is not needed with the Keelan forceps, which have a different design. And here shows, again, this type of rotation being done with a pair of Simpson forceps. Vacuum extraction, again, you have the instrument, which is a cup, followed by a piston device, which produces the vacuum. The key to successful vacuum extraction is getting the cup on the right place, known as a flexion point, which, again, if you draw a straight line from the occiput to the chin, this is where you would want this in a perpendicular. And as shown here on top of the head is 2 or 3 finger breadths below the anterior fontanelle, just over part of the posterior fontanelle, and that basically by applying it here, you reduce the chances, particularly of extension of the head during the course of extraction with the device. Again, you follow the planes of the pelvis, depending on where the head is exactly. Also, with the vacuum, in many instances, you also will have a vector that actually goes upward as you complete your delivery. Here shows, again, traction being applied. Oftentimes, it's helpful to have one hand against the actual cup to, again, determine whether, in fact, that the cup is well applied and is not on the verge of pop-off. Remember that the fetus has to be more than 34 weeks. The risk of cephalohematoma, by the way, is related to the duration of the pull overall, and there does not appear to be any difference in cephalohematoma risk if you reduce the pressure in between pulls. In general, 3 pop-offs is sort of the rule that many people use, but there's limited data supporting whether that should be an absolute. And here's the modified Ritkin maneuver being used to basically deliver the head at the end of the traction. The last type of delivery that we'll talk about is the use of forceps on the after-coming head with a breech presentation. Here's the Piper forceps, which are unique in that they have also a perineal curve, which allows application below the fetus's trunk. Here's application of the left blade. The assistant holds the fetus, can either in this fashion shown here or using a towel as a sling. The left blade is applied with a handle dropped about 45 degrees and with the handle towards the midline, and is applied over the ear as shown here. Once that is accomplished, same thing with the left blade, angulated down about 45 degrees below the horizontal and applied similarly. If there's a lot of resistance, one can wander the blade around the fetal scalp in an effort to get it applied. Once both blades are on, you articulate them together and lock them. The fetus can either rest on top of the actual blades, as shown here, or assistant can hold it with a sling. And again, traction is downward until the chin is seen, and then one elevates with traction to deliver the rest of the fetal head. And again, this shows how the actual traction would occur. So with any type of obstetrical operation, there are risk complications, both maternal as well as fetal. The major risk from a maternal standpoint is third and fourth degree perineal lacerations, also known as oasis type lacerations. And this is a meta-analysis of 22 studies involving over 650,000 women, where the overall rate of third and fourth degree lacerations, or oasis type tears, was 2.4%. However, there are a number of risk factors which increase the odds ratio. In other words, increase the risk by X amount. For example, forceps delivery had an odds ratio of 5.5, again increasing the risk of this type of laceration. Vacuum delivery had roughly a fourfold increase associated with it of this type of laceration. When you combine forceps plus a midline episiotomy, third degree laceration, there was about 5.5 increased risk and about 10.5 for a fourth degree laceration. When you look at women who just complain of symptomatology and may not have this degree of, shall we say, injury, many still will complain of defecatory symptoms. And this is from a study where they interviewed women during the first year after a delivery and did, in fact, show that forceps delivery as well as vacuum deliveries were associated with increased risk of complaints of defecatory symptomatology. And obviously there can be issues relating to the neonate as well. And this is from a study of 83,000 singleton primogravidas in California between 1992 and 1994. And as you can see that the use of forceps alone and vacuum alone did increase the risk of intracranial hemorrhage, and in particular when you did a C-section after attempted vacuum or forceps, that risk went up even higher. Also, doing forceps and vacuum in a consecutive fashion when one failed and the other was used, again, also increased the risk, and also increased the risk of other injuries such as facial nerve injury, brachial plexus injury, seizures, CNS depression, as well as need for mechanical ventilation. With the vacuum extraction, there is a risk of about 2 to 4% of subgaleal hematoma. There also is increased risk of neonatal jaundice, and this seems to be related to the occurrence of cephalahematomas. However, when you look at long-term sequelae comparing normal vaginal deliveries versus vacuum, there seems to be no significant difference between the two. So in summary, operative vaginal delivery is still an important part of obstetric care. Remember, the alternative, which is cesarean delivery, also has its risks. Certainly, appropriate use of operative vaginal delivery can expedite delivery when needed and avoid cesarean delivery. Certainly, practitioners must know the risks and benefits and convey them to the patient. In addition to a knowledge base, practitioners must also develop and maintain the skills to safely use these modalities.